and thank you, everyone. I have the pleasure of introducing our first speaker for today, Dr. Cardinale Smith. Dr. Smith is an associate professor of medicine in the Division of Hematology and Medical Oncology and the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. And she is the Chief Quality Officer for Cancer Services at Mount Sinai Health System. She is a medical oncologist and palliative care physician whose clinical practice is focused on lung cancer and palliative care. Her research interests focus on the doctor-patient relationship and communication, evaluating treatment disparities in cancer care, determinants of cancer patients' quality of care, characterizing the barriers to optimal cancer care and palliative care, and developing approaches towards eliminating those barriers among racial and ethnic minorities. Dr. Smith is the 2013 recipient of a mentored research scholar grant from the American Cancer Society to evaluate determinants of disparities in the utilization of palliative care among patients with lung cancer. She is also the co-investigator of a Patient-Centered Outcomes Research Institute grant to teach and enable goals of care conversations among oncologists. Additionally, she is the recipient of the Sojourner Scholar Leadership Grant and R01 from the National Cancer Institute to evaluate the role of impact of implicit bias among oncologists on minority cancer patient outcomes. Dr. Smith has had numerous publications in peer-reviewed journals, and in 2015, she was named one of the top 40 inspirational leaders under 40 by the American Academy of Hospice and Palliative Medicine. Dr. Smith, thank you so much for being here today.
Thank you so much for having me and for that very kind introduction. I will say probably the saddest part of all of that is I am no longer under 40, but that's okay. Growing old gracefully, as they say. So it's a pleasure to be here with you all today, and I will be speaking on disparities in cancer pain management. I will sort of set the stage in my talk for where the evidence currently sits, and what are some of the contributing factors that we may be seeing with both the patient, provider, system, and regulatory barriers to effective pain management. So Dr. Martin Luther King Jr. said of all of the forms of inequality, injustice in healthcare is the most shocking and inhumane. And indeed, here we are 60 years later, where we are still dealing with that. And COVID has, I think really shed a light on that in a way that we haven't seen previously. And so I'm going to share a little bit about my own story about both how I got into this work and how this, impacts all of us. So this is a younger pre-baby version of myself on my wedding day. And the gentleman standing next to me is my father. I'm told I look a lot like him. In fact, I'm named after him. His name is Cardinal and I am Cardinale. This was in September of 2005. And what he hadn't told me was that for the last 4 or 5 months, he'd been experiencing rectal bleeding. And he later went on to share that he didn't want to tell me about that because he knew I was wedding planning and I was in residency, and he didn't want to worry me or bother me. He was 52 at the time. He had never had a colonoscopy because, like many of the beliefs we hear around men, and particularly men of color, around of having colonoscopies, he held a lot of those same myths and beliefs. And so in April of the following year of 2016, he was diagnosed with stage 4 rectal cancer. 2006, he was diagnosed with stage 4 rectal cancer. And in this picture here, this is a year later. And although a little blurry, you can see that he's lost a lot of his hair. His skin has gotten a little bit darker. He has aged. He had been on chemotherapy for his cancer for several months. And the baby in that picture is my niece. It's his first grandchild. And what we experienced during his cancer care was, while I think we got expert cancer care and we had access to expert palliative care clinicians, unfortunately, we had a really hard time getting the opioids that he needed for his pain. So he lived in Brooklyn, and he would go to his local pharmacy to fill his fentanyl patch or his Dilaudid for breakthrough pain. And the pharmacist either didn't have it in stock, didn't want to order it, or if he came a day or two before the prescription would be filled, he was accused of diversion. And in fact, his oncologist got many phone calls about, are you sure this is what you want to do? Sort of questioning what he was doing. And ultimately, what I ended up doing was filling his prescriptions in Manhattan at the pharmacist near the hospital where I work, because I knew they would have it in stock, and I knew that we wouldn't be subjected to the same challenges. And this is him in 2017. Now, my niece in this picture was about 10 months old, and this was about a month before he died. He was home on hospice. And, what this experience brought out for me is, I like to consider myself fairly educated and savvy in terms of being able to navigate the healthcare system. But when it really mattered to be able to get my dad the kind of pain relief that he needed for his metastatic cancer, we couldn't do that. And it was because of who we are. And so that is what sparked my interest in this work. And when we think about what health equity is the attainment of the highest level of health for all people. It's a way to address the avoidable inequalities, historical and contemporary injustices, and ultimately to eliminate health and healthcare disparities. And when we think about equity, people often confuse this with equality. So equality is giving community members or people the same level of resources. But what equity says is that we recognize that not everybody comes to the table with the same amount of resources. The road traveled is very different. What they are able to have and how they are able to obtain things are very different. And therefore, we will give those who need more assistance more, while giving those who need less. And that's how we get to everybody being on the same level playing field, or how we start to get there. And of course, this is multifaceted when we talk about healthcare, in that it is equity of access, of treatments, and of course, outcomes. And so we'll talk a little bit about what may be contributing to some of the inequities that we see in pain management for cancer. And so, going through some historical and contemporary injustices, this is a picture of Dr. Marion Sims, who was a gynecologic surgeon in the South. And many of the modern day surgical gynecologic techniques are based off of techniques that he developed. And he did that by operating on Black women slaves in the South. And he perfected many of his techniques on them. And although anesthesia certainly did not exist then in the form in which it exists now, he did not offer any of these women anesthesia because of this belief that Blacks are able to tolerate pain differently or better, or they don't experience pain in the same way. And then there's the story of Henrietta Lacks. The name of this book is The Immortal Life of Henrietta Lacks. If you've not read it, I highly suggest it. It's really an interesting look into how these injustices that occurred, even in the 40s and the 50s, still permeate and percolate and are experienced generations later. And so Henrietta Lacks was diagnosed with cervical cancer and was treated at the Johns Hopkins University, back when there was an area for Blacks and an area for whites. And at the time of her biopsy to diagnose her cervical cancer, what they found is that her cells were able to continue to grow in perpetuity. So they were called the first immortalized cell lines, meaning that they grew on their own without the addition of any, additional media or work to do so. And because these cells just continue to grow on their own, they really were instrumental in creating many of the treatments that we have today, like the polio vaccine. And yet, when you read the book, her family didn't know that her cells were being used in this way until much, much later. And they certainly didn't receive any compensation when you think about all of the money that was made from all of the things that the cells helped to create. And then, of course, probably the most infamous is the Tuskegee syphilis experiment, which started in 1932. And at the time, researchers told men that they were being treated for quote unquote bad blood, which was a local term used to describe numerous ailments, also including syphilis. And they studied what happened to these men with syphilis, the natural trajectory of syphilis. And this was despite the fact that in the mid to late 40s, penicillin was identified as a treatment for syphilis. Ethics concerns were raised, but the CDC reaffirmed the need to continue the study. And then in 1972, it came out that this study had been ongoing for 40 years. I mentioned that I'm no longer under 40, so I was born in the 70s, but the late 70s. And when you think about this, this coming to light in the 70s, I was born in the 70s, right? So it is something that is still very much top of mind for many people of color, particularly those who identify as Black, because this is something that is contemporary, that happened in their lifetime. And so you can see it. And it does shape the way in which folks both access and connect to care. Some additional differences that are likely contributing to this include this false belief about biological differences. So this study looked at lay folks in the community, that's study 1, and then study 2 looked at first, second, and third year medical students, and then they looked at residents in training. And they asked a series of beliefs to get a sense of who believed what. And so for the question, Black's skin is thicker than white's, almost 60% of lay community believed that. And it ranged anywhere from 22 to 42% of those who were in some form of training, medical training. For Blacks age more slowly than whites, while I may selfishly wish that to be true, I don't think that we have any evidence that that in fact is the case, and yet 23% of the lay community believes that, compared to anywhere from 12 to 28% of those in medical training. And when we look at the composite of all of the false beliefs, about 22% of lay community believe these false beliefs, compared to anywhere from 5 to 16%. And while 5 may appear low, it does impact the way in which we as clinicians embrace and connect to our patients of color. And when we think about all of the different variables that are related to the inequities that we see in pain management, it's really complicated, right? If it was simple, one would hope that we would have fixed this already. But there are certainly patient-related variables, and they go back to those examples that I shared in terms of, beliefs about the healthcare system and what they do or do not do to folks of color. There are certainly the social determinants of health that play a particular role in how patients are able to both access and utilize and receive pain services. There are healthcare clinician-related variables, so our ability to assess pain, to provide adequate guideline concordant pain management and biases. There may be some genetic factors that are currently ongoing and being studied in terms of differences in the way these drugs are both absorbed, metabolized, and eliminated. And then there are healthcare variables, right? And some of those are system-related variables, and some of those are examples that I gave you, which is where you live and what pharmacies you have and how you're able to obtain this information. And we'll talk a little bit about some of these. So when we look at extent of pain in the United States, the majority of pain that is experienced is chronic pain, and cancer pain is not necessarily the most common form of pain received, but it is certainly costly, and it is certainly, it affects the majority of patients who are diagnosed with cancer. If we look at the scope of the problem for substance use, we know from recent data that this tends to be highest among non-Hispanic whites and Native American or Alaskan natives. And yet, and similarly, there is an unequal burden, which is that the rates of illicit drug use are certainly similar across the board, maybe a slightly higher in those who identify as Hispanic, but the drug-induced deaths are higher among those who are white. And yet, when you hear the story, right, about the history of drug abuse or substance abuse, often the images that come to mind is someone who is of color. I think part of the reason why the opioid crisis has become so important and so front and center is because the face of that, is really not someone of color. It's often someone who is white. But yet our own beliefs about who suffers from this the most taints the way in which we approach the management of patients. And so the consequences of pain, and particularly when pain is not managed well, is that it impacts our physical function. It certainly impairs our family roles and dynamics and our ability to engage with loved ones. There's a financial cost to this, right? We may miss days of work. We may not be able to function in jobs in the same way. And then, of course, it has a psychological impact in terms of contributing to depression, anxiety, and other mental health conditions. And so here in 2006 was a New York Times article that says, finding good pain treatment is hard. If you're not white, it's even harder. And when we think about some of these things, we've talked about these particular factors contributing, and we'll go into them now in a little bit more detail. Overall, when we look at minorities and pain, we find that minority patients with pain have less access to pain management. They're less likely to have their pain recorded or assessed. We know that they receive less medications, and they're at risk for undertreatment. And when we look at underestimation, specifically looking at clinician barriers, this study looked at patient and physicians' perceptions of pain in 12 academic medical centers. And they found that physicians underestimated pain in about a third of non-Black patients when compared to almost half of Black patients. And so when patients are presenting and telling us about their pain, they're already being underestimated and believed to be not having as significant pain as is being expressed. And then when it comes to prescribing, we see even more disparities. So that this meta-analysis looked at a multitude of articles that were published between 1989 and 2011 and looked at differences by race and ethnicity groups in terms of prescriptions of any analgesic medication, and then looking at specific prescriptions of opioids, of non-opioids, and this would be, for example, acetaminophen or any of the non-COX-2 NSAIDs like ibuprofen, for example. What you see here is that when we look at Hispanics compared to whites, there was less prescribing of opioids. When we look at Black patients compared to whites, they had less prescribing of any analgesia, which included opioids and the COX-2 inhibitors. And if we look at these subgroups a little bit more in detail, again, we see that those who identify as Hispanics, and Blacks certainly report different qualities so that the quality of the care that they're receiving is less. And so not only are we not adequately ascribing to the pain that minority patients are telling us they're having, we're not prescribing adequate pain management for them, and that is contributing to lower quality of care. And that's on the clinician side. So here we have the slide, the gentleman telling the bartender, the great thing about self-medicating is that there is a low copay. And if we look at now some of the system barriers in terms of access, so we already know that the access is low because we as clinicians are prescribing less. But then there are also barriers in terms of pharmacies and where patients go to get these medications. And so this study done now 21 years ago, and it will be really interesting to see an updated version of this now in 2021, looked at the adequacy of opioid supplies at pharmacies according to racial and ethnic composition of the neighborhood. And this was done here at Sinai, so it was New York City. So it looked at the Upper East Side and then the Harlems and the South Bronx. And what they found was that in those communities that had higher composition, higher proportion of folks who identified as white, they were more likely to have adequate opioid stock in their pharmacy. In those communities in which the composition was comprised of higher proportion of Blacks and or Hispanics, those pharmacies were less likely to have adequate opioids in stock. And when those pharmacies were asked why, they reported that about half of them reported that there was little demand or they were concerned about disposal. About 20% reported fear of DEA investigations or robbery. And about 7% were concerned with reimbursement. And this was done in New York City, right? So, all right, is that the same everywhere? Well, this has been replicated in other urban environments. So here, this was done in Michigan. And what they did here is that they looked not only at the racial and ethnic compositions, but they looked at the income. So essentially, is this only about race and ethnicity, or is socioeconomic status also playing a role here? And what they found were that these Michigan pharmacies in minority zip codes were 52 times less likely to carry sufficient opioid analgesics than pharmacies in white zip codes, regardless of income. So essentially, if you are, regardless of whether you identify as Black and you are in a low socioeconomic status or a high socioeconomic status, regardless of that, you are still less likely to be in an area where pharmacies carry adequate opioids. And so it gets us to this place, right? The system isn't broken, it was built this way. And so how are we structurally putting things in place that may be preventing those who need it most and those marginalized communities from receiving the care that they need? So the prescription drug monitoring program and the electronic prescribing of controlled substances is something that has really come to the forefront within the last 5 to 10 years. And prescription drug monitoring essentially looks different depending on what state you're in. And what the prescription drug monitoring program consists of is that there is some centralized database by which the clinician can log in or the pharmacist can log in, and they can get a history of all of the controlled substances that has ever been prescribed to you, and when it has been filled and where it was filled and who wrote the prescription. So it was meant to be a way to really understand and to see, sort of get a sense of the drug shopping that was pretty prevalent and was going on. It was a way for clinicians to be able to go in and to see what that looked like. And there are some states that have required that you do it. So that in this map, the light blue states have a mandate for the prescription drug monitoring program, such that if you are a clinician prescribing a controlled substance, you must log in to the program to see what someone's history has been before you prescribe. The states marked here in yellow are the states that have both the prescription drug monitoring program and they have electronic prescriptions of controlled substances, so no paper. And you can see that's just a few states, of which I happen to live in one. And then the dark blue are those who currently have the prescription drug monitoring, but are planning for electronic prescribing. And then that one state, the one orange, is that there is a future electronic prescribing mandate. The white are those states which have neither. And while well-intentioned, one can imagine that it's all in how it gets operationalized, right? So I can tell you in New York, I'm told I'm supposed to go into the PDMP anytime I'm going to prescribe for a patient, and I do because I'm a good citizen, but not everybody does that, and you don't have to do that, and there's no way to check and ensure that you are doing that. And for some, it's seen as another barrier, right? So I can only talk about my experiences in New York because that's where I am. But when I want to go log into the system, my username is some ridiculous thing that I couldn't pick for myself, with some combination of my name and lots of numbers that I can't remember. And then the password is a password that is unlike any password I've ever had to make for myself. And I change it so frequently, I can never remember it. And it's not like it's simple two-factor authorization to change my password when I forget it. In fact, the steps are much more than that. And so one can imagine that the more barriers we put in place, which I absolutely understand why that was done when we think about the opioid crisis, but now it's creating even more structural barriers for groups that were already being marginalized. And if we look at what happened as a result of the PDMP's sort of early data, and this was published in 2007, looked at those states that had a mandate to use it, or a mandate to register, or no mandate at all. And there certainly was a difference in terms of the number of Medicaid enrollees who received prescriptions based on whether there was a registration or a mandate and registration, meaning those who had both, there were less prescriptions for those on Medicaid. And then here, this looks at spending, and that definitely, spending was decreased if there was some mandate. But the question is, well, what is this doing to patients, right? So this is telling me that prescriptions are happening less, that I'm decreasing cost, but it's not telling me who's getting prescriptions less, and what is the outcome of that, right? I would imagine that many of these are appropriately less opioids, but not all of them. And if we look at other potential barriers, states have certain laws setting limits on opioid prescriptions. So in New York, for example, our former governor, his daughter went to have her wisdom teeth removed, and she received a prescription for a month's supply of Vicodin. And that was the impetus for him to put this in place in New York State. And many states now have statutory limits for patients in terms of the number of opioids they can get for a first-time prescription. And then some states are now putting in limits on the total morphine milligram equivalents that someone can use. Now, they all have these, sort of the fine print that says, if someone has active cancer or serious illness or on hospice, that these rules don't apply. But when you're in the state that has electronic prescribing, or even if you still have a paper system, how do you translate that information to the pharmacy? Do you remember to check off that box when you fill the prescription? Is it done automatically? And then if you don't do that, what happens when the patient goes to fill it? Are they getting it? Because if they're not, then how long is it going to take for the pharmacy to call and say, or the patient to call and say, hey, we couldn't fill this prescription for your patient. Can you give us more information? What do you need to do? And so this here are a list of folks who also have either prior authorizations on the opioids that we need to do, that have enacted their own prescription limits for acute pain. And I put some of them here. So even outside of what states are doing, there are both local pharmacies and payers that are starting to put limits on this as well. And so, you know, again, an article in the New York Times that says new opioid limits challenge the most pain prone. And it's true. And I think part of what we will need to do as a community is understanding who's being impacted by this and what that impact is. And essentially, this is where we get to this vicious cycle where we know we have opioid injustices. You know, we're limiting the access to opioids, and it becomes a double-edged sword, right? So that we are sometimes limiting for those who need the most. And so what are some of the things that we might be able to do to address this? Well, certainly thinking about enhancing access, you know, thinking about our communities and our pharmacies, you know, what do those pharmacies, what are the composition of those pharmacies? Who stocks adequate opioids? Who doesn't, and why? For example, I know one of the things that we do here, and other institutions do this as well, is whenever we're sending someone home with either a new or a changed prescription of an opioid, we contact a local pharmacy. We make sure that the prior authorization gets done if it needs to get done, and we have the meds delivered to the bed so that when the patient goes home, they have it in hand. You know, I think that there are certainly cultural differences that need to be addressed. For some cultures specifically, there may be this belief around stoicism that, you know, requires an open conversation about what the goals are for opioid treatments and what the risks and benefits are. I think care coordination is a really huge part of all that I've just talked about, because the system can be really challenging, and it's particularly hard when you know, we're dealing with populations who may have low health literacy and who have other social determinants of health and other structural barriers that are really impacting their ability to connect to care. I think clinician bias is another really important part of this. And when you think about bias, specifically implicit bias, right, which is unconscious and isn't at the forefront and something that we tend to not think about, that gets activated in periods of stress. And so when you think about what periods of stress exist for physicians and other clinicians, right, it's those visits, right? So if I think about the 20-minute follow-up visit that I have with a patient with advanced lung cancer, in 20 minutes, I'm finding out how they're tolerating their treatment, dealing with the side effects they're having from that treatment. Perhaps I'm engaging with the caregiver in the room, both for the caregiver distress and other issues that might be coming up. And I have to do all of that in the span of 20 minutes because I have 10 more patients waiting for me. So we set up this environment of high stress, a sort of high cognitive load that makes it really challenging for folks to think through decision making. And so what ends up happening is we fall to stereotypes, or we associate the patient in front of us with a similar patient whom we saw. And what that ends up looking like, particularly for people of color, for those who identify as Black and Hispanic, as either being seen, you know, as substance users or abusers, or not believing or understanding the true impact of pain. And then I think lastly, making sure that we improve access to specialty palliative care or supportive oncology in our cancer population, I think, which is, you know, a really great way of providing more patient-centered holistic care, recognizing that pain isn't just physical pain, but there are other multi-dimensions of pain that can be addressed and often exist more among our communities of color. And so FDR said, the test of our progress is not whether we add more to the abundance of those who have much, it is whether we provide enough for those who have little. And so with that, I would like to end my talk and thank you for your attention.
Dr. Smith, thank you so much for all that you just shared, for also sharing your own personal story with your dad, and all of this important information about the many inequities that are present in our healthcare system. We just have a couple of minutes for questions, and I guess I'll ask you one if you don't mind. You mentioned a lot of the systems barriers that contribute to the health inequities and prescribing inequities. But in one of your slides, you showed a table that showed that there was differences among clinicians prescribing practices. That what do you make of that? What do you think contributes to the disparities inherent within clinician prescribing practices?
Yeah, I mean, I think that this gets to bias. I think that there's bias, whether it is implicit or explicit. But if, if there is this belief that we hold that the level of pain being reported isn't as severe as in fact it is, then that contributes to us not prescribing as much. And similarly, if we hold false or stereotypical beliefs about who is more likely to be a substance abuser or a drug seeker, and we ascribe it to those particular populations, then we're also less likely to prescribe.
Well, thank you again for all that you've shared with us.